tonight's discussion, New Directions in Healthcare. I'm Aaron Segi, I'm Vice President of the Promoting Student Union. PSU is a nonpartisan, student-run organization committed to raising the level of open and honest dialogue on campus. Underpinning the goals and aims of our organization is a tenet that one cannot possess a firm belief in anything unless it is power. To increase informed decision-making in current and beyond, we seek to foster an environment in which students are exposed to a multiplicity of perspectives. Also, please mark your calendars for this year's great debate, which is going to be on Me Too, Where Do We Go From Here? It will be in exactly 3 weeks from today, on Tuesday, April 24th, in the Rose Hill Theater. So, hoping to see you all there. So tonight we're talking about healthcare. 30 million Americans have no health insurance, and the U.S. spends twice as much on healthcare as other wealthy nations, but we have poor outcomes. A study published by researchers at Harvard's Chan School of Public Health just last month confirmed this for 2016. And so healthcare, with its enormous impact on people's well-being and livelihoods, has been one of the central conflicts of our politics for years. Last year, the Republican-controlled Congress introduced several bills to repeal the ACA, or Obamacare, but none of them passed the Senate. In December, though, the individual mandate, which was a key provision of Obamacare, was repealed. Since then, healthcare has been a little bit less in the news. Behind the scenes, it's a fertile time for ideas. This is particularly true on the Democratic side of the aisle, as the left debates its vision for healthcare. The Medicare for All bill, sponsored by Bernie Sanders and Congressman Ellison, in in February, the Center for American Progress released a comprehensive public option proposal called Medicare Extra for All. 2 weeks ago, Senator Elizabeth Warren introduced a bill to expand subsidies and increase requirements for public insurance. So a lot of ideas are kind of continuing to be discussed. So in this time, we are super excited to welcome two distinguished speakers tonight. Dr. Paul Song is a radiation oncologist. He graduated with honors from the University of Chicago and received his MD from George Washington University. He's also Chief Medical Officer at Sinvenio Biosystems, a biotech firm, and is co-chair of the Campaign for Healthy California, which advocates for a Medicare for All system in this state. Professor Gerald Kominski is a professor of health policy and management, and just yesterday stepped down as director of UCLA Center for Health Policy Research, which he had led for 24 years. Dr. Kominski received his PhD as assistant director for AT,
yes.
Director.
I was going to say for Browns.
He received his PhD in public policy analysis from Pennsylvania Wharton School in 1985, and his AD from the University of Chicago in 1978. He works extensively on evaluating the expected impacts of healthcare reform, and has led the development of a simulation model for forecasting the eligibility, enrollment, and expenditures under proposed healthcare reforms. Before joining UCLA, he served for 3.5 years as a staff member at the agency now known as the Medicare Payment Advisory Commission, and is co-author of over 120 articles and reports. So please welcome our speakers today.
And we're going to kick off the discussion with the first question is, what does the state of United States healthcare look like today? And Dr. Paul Song has a brief presentation for us.
And I must say that I'm always honored to be on the same panel with Dr. Kominski, but we've been on several. This is the first time I've found out he's also a fellow University of Chicago.
All right, and so I have to comment on that real quickly. So I find it highly ironic that two graduates of the University of Chicago, which is, among many things, for being the origin of the Chicago School of Thought, Milton Friedman and market economics, that two graduates of the University of Chicago are here discussing a single-payer system and socialized medicine. So,
but along those lines, Milton Friedman did once say that he thought that the third-party payer system was wrong.
Exactly.
Right.
Exactly.
So thanks so much for having us. I'm a radiation oncologist by training. I've been in practice for over 20 years. But about 5 years into practice, I started to see too many of my own patients who were getting cancer really suffering financial hardship, and I started to say, what's wrong with our healthcare system? And from that's where I really developed a voracious appetite for learning a lot about healthcare. And I actually read a lot of Dr. Kominski's work, and from that kind of came across my own conclusions about what was wrong with our healthcare system. But I would ask you all to go into it agnostically and really look at the facts and kind of figure out what you think is the best based on the information that's out there. Having said that, I just want to give you a few slides of where our current system is. And the thing is, our system is so multifaceted that it's not one particular system. Everyone thinks we have a basically private system, but this is just putting in perspective that we're a hybrid of multiple countries. So you have the socialized medicine system that Denmark and Britain have, which is where the government owns and operates every aspect of the healthcare system. They own the hospitals, they employ the doctors, they own the pharmacies, the radiology equipment, the labs, everything. And we have that system here, and ironically, the term that's socialized is our VA system, or military healthcare system, where and I will say this, prior to the Iraq War, I was actually working at Walter Reed for 2 years, doing all the prostate implants there, right when the war happened. And I will tell you, back then, the VA system and the military system was really running great. What happened was the Iraq War, they were not prepared for sort of the carnage that they had never seen before. Between the body armor and everything, people were surviving that normally wouldn't have survived, and that's why you have a lot more people coming back with head trauma and things, and that really overwhelmed the system. But that's our socialized medicine system that exists in the United States right now, is our VA system. The employer or employee-sponsored system is very similar to what Germany has, which is what the majority of Americans get their coverage through their employer. And then we have Medicare, which is our single-payer system, although we can get into that a little bit more. There's been a lot of privatization that's introduced private insurance into that, but if you look at Canada's single-payer system, that's sort of aligned to Medicare. And then this was pre-ACA, now we have about 30 million that are uninsured, and that's very similar to Burma and Burundi, where you have to pay cash or you get sick and die, right? So these are, to recognize that it's very difficult to just pigeonhole our system into one particular healthcare system. We have numerous systems all into one, and that's part of what makes our system so complicated. So you'll hear, speaking of two U of C guys, this whole debate between the free market or socialism, right? So you have Adam Smith and you've got Lenin. And just to point out where the term socialized medicine came about was when Ronald Reagan actually was an actor. Before he went into politics, the American Medical Association hired him to record this album. And the idea was this is in preparation to oppose Medicare. And the idea was that doctors would take this album home and they would give it to their wives, and wives would have afternoon teas and play this for everyone in their neighborhood to educate them on why Medicare was bad. But back in 1961, Ronald Reagan said, if you don't stop Medicare and I don't do it, one of these days you and I are going to spend our sunset years telling our children and our children's children what it was once like in America when men were free. So that was really the first time you started to hear this concept of freedom versus the government-run healthcare system, and the whole concept of socialism came about from this. And so when in the run-up to the ACA, I was debating Ron Paul, and Ron Paul said, we don't need more government-run healthcare, what we need is more freedom. And let me just point a couple things out about that. One is you heard that the ACA was going to be a job killer, or any government-run healthcare would be a job killer. And this is just showing you when the Affordable Care Act was passed, and what's happened to job creation ever since then. So the idea that somehow government mandating, giving healthcare was going to kill jobs strictly is not borne out facts. And then over here is from the Heritage Foundation, a very conservative think tank that ranked all the countries in terms of economic freedom. And if you'll notice, all but one country that's ranked above the United States has a higher economic freedom, but they also have universal health care. So we need to get beyond the idea that universal health care is anti-competitive or takes away economic freedom. Matter of fact, Charlie Munger, who is Warren Buffett's right-hand man, said, medical costs are the tapeworm of American competitiveness. Our cockamamie system gives our companies a big disadvantage in competing with other manufacturers. They've got single-payer medicine and we're paying for it out of our company. And if you notice, this is for 2018, the average employee healthcare plan will cost about $14,000 per employee. Actually, a lot of places it's even more than that. So this is just showing you what has happened to insurance premiums. This is only from 2002 to 2011. Premiums have gone up 153%, whereas inflation has only gone up 29%. But if you extrapolate that out to 2018, insurance premiums have now gone up over 200% during that time. Meanwhile, wages, as you can see, have remained relatively stagnant. And not only that, workers are being asked to contribute much more of their paycheck. So even if you get your coverage through your employer, you're being asked to contribute more towards your health care, both in terms of towards your premium, but then when you get sick, you're asked to pay more in terms of co-pays or deductibles. So as a result, the average worker gets less take-home pay. And prior to the bailout, General Motors was actually spending more on health care than it was on steel to make cars. But just to show you, not everyone's doing bad in this environment. Just got a few more slides. Now, in the run-up to the ACA, there were 3,300 registered healthcare lobbyists for the 535 members of Congress. They were spending over $1.2 million a day, and in total, more was spent on lobbying for the ACA than on the Bush-Kerry election. And that's why the ACA, while it did some good things, had no insurance rate regulation or drug price controls. And that's what I really want to point out, how this has come home to roost. The Lancet, which is a very reputable healthcare journal, devoted a special issue to this, saying the healthcare reform process exposes how corporate influence renders the U.S. government incapable of making policy on a basis of evidence and public interest. So if they had spent a lot more time looking at Dr. Kominski's research, I think we would have had a little bit different bill. So just to point out, the individual mandate is nothing new. It was proposed in 1971 by Richard Nixon as an alternative to Senator Kennedy's national health insurance proposal. If this is where we are right now, we have roughly 154 million Americans, so roughly half of the people in our country get coverage through their employer. You've got 46 to 50 million that get through Medicare, and there's now 23 million that have now gotten coverage through the ACA. And certainly we've had a lot of positives. The number of uninsured has dropped. These are just some of the benefits. Some of you have been able to stay on your parents' plan now until the age of 26, if no lifetime caps, things of that nature. So there was a lot of good in the plan. But this just came out this last month. This is from a survey that was done in February by the University of Chicago. Sorry to make this so maroon-centric. But this is just saying that now when they surveyed Americans, most people in the nation do not believe that they get good value for what we spend on healthcare. 74% believe that. And that if you look, more Americans now are afraid of paying for care than of getting a serious illness. The other thing is that if over the last 12 months, there were 44% of people reported not going to see a doctor when they were sick or injured because of cost. 40% went without having a routine physical. 40% skipped a recommended medical test or treatment. And then also the number of people that were sent for medical collection has increased. And then also, I want you to focus really on the line on the left, which is the insured. If you look, the number of people that report being unable to pay for food, heat, or housing who have insurance once they get sick is roughly a third of people, right? And so that tells you something about the coverage, right? What's with our coverage that people can't afford to just maintain their basic quality of life. Last thing I'm just going to point out is that, to sort of set where we are, is this is by the Kaiser Family Foundation in 2015 versus 2017. It just says that the number of people that report having difficulty paying for their insurance premium every month has increased now from 27% to 37%. And then the column on the far right is the number of people that have difficulty paying for their deductible is gone up from 34% to 43%. So while the ACA has done a lot of good things, this is sort of where the state of our healthcare system is right now. And I just wanted to give you that information as sort of a baseline from where we can have a discussion. So we can turn this off, right? We're not blasting anything else.
Thank you, Dr. Song, for all of that. So we kicked off the discussion then with what's not going so well in healthcare today. And you touched on it, how the Obamacare's individual mandate has recently been repealed. Could we go over a little bit of what exactly that means right now and what it means in in real people's lives?
Sure. So the repeal of the individual mandate that was part of the tax bill that was passed in December means that you'll no longer have to prove when you file your income taxes that you have a qualified health insurance or pay a penalty. And the latest figures I've seen from the IRS is that I think roughly 6.5 million Americans are currently paying the penalty rather than buying insurance. So, there'll be 6.5 million people who will immediately be better off as a result of this. They obviously don't want insurance, don't feel that they need insurance, and they'll no longer have to pay this tax penalty. The other question is, or the issue is, how many people will now decide that, well, I was only getting health insurance coverage because I didn't want to pay a penalty and not have coverage, so I may as well pay a little bit more and have health, at least I'll have health insurance in case something goes wrong. CBO, the Congressional Budget Office, has estimated that in the next few years it'll be as many as 13 million nationally will drop coverage. We tend to think, my research colleagues at UCLA and Berkeley who've been looking at this tend to think that that number is a little bit too high. There's a new study that just came out that suggests that 90% of people who are insured will keep their insurance. So the number who will drop is going to be less than expected. But when the Affordable Care Act was passed, the mandate was considered one of 3 essential components. And because Republicans and the president don't have the votes in the Senate to fully repeal the Affordable Care Act, this was something that they could do without 60 votes. They could do it through the budget reconciliation process that required 50 votes. Republicans like to cut taxes, and so putting this into a tax bill made sense for them from a political perspective. I think it will be mildly damaging to the ACA, and that's the strategy right now. If we can't repeal this law completely, let's continue to inflict damage on it so that people will lose confidence, and then it will be a self-fulfilling prophecy. The president has been saying for a long time that the ACA is dead. Other members of Congress have been saying it's imploding under its own weight. And if you keep damaging the law and undermining confidence, it may become a self-fulfilling prophecy.
And do you have an idea, you hear that by repealing the individual mandate, it increases premiums for everyone?
Oh, yeah, well, it will certainly do that. So, and the reason for that is, who are the most likely people to drop insurance coverage? People who really probably don't need it immediately. Relatively healthy individuals, people who say, I've never been sick a day in my life, I don't need health insurance coverage. As a result, people who are more likely to keep coverage are people who maybe have chronic illnesses, spend more on an annual basis. You don't have to be severely ill to have, a few chronic illnesses that require regular prescriptions, require regular visits to the doctor, diagnostic tests. So higher cost individuals will be more likely to keep their insurance, and when lower cost people drop out of the market, by definition the premiums have dripped up. Again, CBO's estimate is that it's going to be about a 10% increase. It's not enormous, but it will make a difference. People will drop coverage just as a result of seeing a 10% increase above and beyond whatever else is going on in the healthcare market.
So the Republican agenda seems to be to tear down the ACA kind of piece by piece. What do you think that the left should be doing to counter or to reinstate better healthcare?
Well, I think that's the challenge, because as Dr. Kominski mentioned, they've been able to use reconciliation tactics where you don't need to go through the Senate 60 vote threshold. The other thing is, I will say that while the ACA their repeal of the ACA failed, they've been doing a lot of other things to undermine it, such as removing the premium support rate for the cost-sharing reductions, so that you know, a lot of things have really been starting to fall apart. But I think there's really no recourse for the Democrats right now. So.
Yeah, I mean, it's difficult because under a different administration, there would have been, instead of seeing efforts to dismantle the wall or damage the wall, what you would have seen is an acknowledgement that this was a good first step, but there are continue to be problems. Dr. Song identified some, you know, people still feel vulnerable, and it's not just because they perceive vulnerability. There are people who still are paying, have very high deductible plans under the Affordable Care Act. And outside the Affordable Care Act, again, based on the data that he presented, there are 154 million Americans who have insurance through their place of employment. More people with employment-based insurance have high deductible plans today than 15 years ago. In 1999, high deductible plans virtually did not exist anywhere in the health insurance market. Now they are pervasive. Almost everyone is, almost all employers offer a high deductible plan. And it's very attractive to employees who, again, are generally healthy to select the high deductible plan because it's a lower premium. And if the employer is not paying the full cost, and very few employers pay the full cost of health insurance premiums, then there's an economic incentive to choose the lowest cost plan, which may be a high deductible plan. So we're seeing more people report difficulty paying bills. And although I don't think either of us have the exact figure in front of us, I didn't look this up before the presentation, but there is recent data that suggests that you know, $6,000 medical bill is a considerable hardship for a significant portion of American families. And there are, you know, high deductible plans. Bronze plans have $6,000 deductibles.
So thinking a little bit more big picture then, what do you think a better alternative would be here in America? So we saw that there's a lot of different systems around the world. What do you think would work here?
So what I think versus the political reality are two separate things.
Right.
In a perfect world, so my parents are from Korea, and I've actually been back quite a bit. And at a time, my uncle, who is was an engineer who became a pastor, developed stomach cancer, and he was going to have surgery at City of Hope, but his copay, deductible, and everything was he had a bronze plan. It was going to be over $6,800 out of pocket, and then 60% of every the total bill was then covered by insurance, and he was on the hook for everything else. So because he had been born in Korea, and he was able to go back to Korea and get the stomach surgery there, and his total out-of-pocket expense was less than $1,200. And you know, again, I think that there's no perfect healthcare system. Certainly people in Canada, you'll hear stories of some people having to wait, in Great Britain, but no one goes bankrupt or develops financial ruin because they're sick. And so I showed you in the beginning, that first slide, the 4 different systems that we have here. But think of also in the private insurance market, you've got HMOs, you've got health maintenance organizations, you've got private insurance, and say one of you has coverage this year through United Healthcare, and then you switch jobs, and then next year you have coverage through Blue Cross. Well, if you go to your doctor's spending a considerable amount of time the next time you come around, am I even in your network? Well, meaning, will your insurance let me see you? And if so, what is your copay? What is your deductible? What am I allowed to do? What am I not allowed to do? That amount of administrative waste really takes money away from the actual healthcare system. And then the idea is that if you could transform it to one universal payer, you would still have the choice of going to any doctor. The doctors would still be working for themselves, or a hospital. But the idea is that you would streamline a lot of that inefficiency. And whether or not you were working or unemployed, you had the same basic coverage. So it's seamless. You could go anywhere. And the idea is that somehow that administrative savings, the simplicity of it, would save a considerable amount of money. And from that money, you could then pour it back into the system. And the idea is also having one universal payer. You could then negotiate better prices from hospitals, from pharmaceutical companies, and things of that nature. Now, people will say, well, that's anti-competitiveness. But what's really interesting is when United Healthcare or Kaiser uses its market share to negotiate drug discounts or get good prices on surgical equipment and things like that, that's considered good free market, good business. But if Medicare tries to negotiate for drug prices, it's considered government interference. If Medicare tries to do bulk purchasing, which it doesn't do. So, in spite of that, I think Medicare has proven to be the most cost-effective system. And if we were able to do that and really look at trying to just maximize our bang for the buck, I think that would be the way to go. But obviously, there's the political reality of that. So,
yeah. So my comments are going to echo Paul's. That what are the political realities versus where ideally should a country like the United States be? Ideally, we should have a single-payer system. This is the most efficient way of delivering health care. It would reduce unnecessary administrative waste that we have. Part of the cost of having so many options and so many different systems, I think your first slide really illustrated that well, sort of depending on where you sit, you experience the healthcare delivery system quite differently in the United States. There are many different systems. It just doesn't make sense that we're spending so much more than every other country and getting outcomes that are mediocre in many cases at best. Not across the board. We have some of the best healthcare available in the United States, unequaled, and that's why we have medical tourism in the United States. Of course, there's medical tourism leaving the United States to go to other countries as well for people who are uninsured and find that it's cheaper to fly to India, for example, to have an operation, and that the full cost of flying there, getting the operation and coming back is still cheaper than if it were done in a U.S. hospital on a cash basis. So, but the fact is that it's why wealthy individuals from all over the world come to the United States for state-of-the-art treatment. But we also have one of the most unequal healthcare systems, certainly among developed nations. And that is, from a public health perspective, what I find so unconscionable. It would sort of be equivalent to saying that we're going to have public education, but it's only going to be available to 70 or 80% of the population. We're going to find a way to keep a certain portion of the population out of public schools, and good luck finding a tutor on your own.
So you're talking about the political realities of adopting a potentially single-payer healthcare system. And are there changes being made right now to pursue that? Are there changes being made in the future? How would we accomplish this if that was what would be best?
So I actually got myself in a lot of trouble about 2 years ago. I spoke at a Bernie Sanders rally, and I referred to Democrats who basically put the interests of corporations, meaning insurance industry and pharmaceutical industry, ahead of their constituents. I used an unfortunate term, and everything got twisted. And I will just say one thing. After I said that, I used the term corporate democratic, and I used this unfortunate term. And immediately everyone said that I'd called the Secretary of State that, and that really wasn't the case. As a matter of fact, Bill Clinton actually called my wife a week later to say that they watched the speech and they realized I didn't say that, and it wasn't intended to her. And he recounted his own battles with the Democratic Congress when he was trying to pass healthcare reform. But the reality is this: we have a system that our elected officials are so beholden to special interests. We see it with gun control, we see it now with healthcare, that trying to even get insurance rate regulation on the Affordable Care Act was a non-starter. So the reality is, this gets back to what Dr. Kominski is really alluding to, the political reality is such that it's extremely difficult. Having said that, the number of co-sponsors, so Keith Ellison, as you mentioned, is now the sponsor of HR 676, which is the Congress bill for single-payer Medicare for all. When John Conyers originally started that, he could basically get a handful of co-sponsors. It now has more than 50% of all Democratic elected members of Congress have signed on to that. And same thing when Senator Sanders introduced his Medicare for all bill 3 years ago, he had no co-sponsors, and this year he had 17. So what's changing? I think more and more people are fed up with the healthcare system that they have. They're looking beyond ideology and they're actually demanding more. And that's how it's going to eventually change. You're seeing it with the Stonewall kids. I mean the kids from Florida.
Parkland.
They're really raising the consciousness and awareness. And I think ultimately that's what's going to happen with healthcare. But it's going to take time. And one of the things I think that a lot of people view is we have to do incremental reform, and certainly maybe nothing's going to happen in the next 2 or 3 years, but I think eventually we'll get there.
Yeah, so I think that as somebody who's studied the Medicare program for most of my career, began my academic career looking at Medicare and then working in Washington, D.C. for a commission that advises Congress on how to preserve the Medicare program and keep it financially viable. Medicare for all is a concept that I support. Now, having said that, Medicare for all means a lot of different things, and I think as soon as someone says that they're in favor of Medicare for all, then the next question is, what version of that do you mean? Because I'm not sure that I agree with the Senator Sanders version of Medicare for all. But I will say that historically, the developers of the concept, and we were talking about this at dinner before this, looking back at the history, Isidore Falk and Wilbur Cohen, who were the two developers of the Medicare idea in 1951, because Franklin Roosevelt decided he did not want to support national health insurance. He was afraid that Social Security would go down in flames if he stuck his neck out on the line in favor of a national health insurance program in 1935. And he gave in to opposition from the American Medical Association, which, by the way, just to remind you, it wasn't Reagan who initiated that. It was the AMA in 1935 who said that national health insurance is the first step towards communism and socialism in the United States and must be fought at all costs. So this idea that we're sacrifice our freedom and we become enslaved by our government if we support national health care, it dates back to the AMA in 35. But Falk and Cohen in 51, when they developed the idea of Medicare, said we're going to start with the elderly, with seniors, because they don't have health insurance when they retire. And they're a deserving population. They're a deserving population because they're our parents and our grandparents. And so this is a social program where we're paying taxes to support our family members in their old age. And for any of you who have aging parents, my mother's going to be 95 next month, if you think about if we did not have the Medicare program, the amount of cost that you would bear, and it's very real to me, the amount of costs that I would have borne in the course of my lifetime. What I will tell you is that I certainly wouldn't be sitting here tonight talking to you because I couldn't have afforded to go to college. It just would not have been possible. So there's an element of financial protection. It's not just healthcare, but it's the financial protection that these programs provide, not only to individuals, but to families. So, the original idea that Falk and Cohen had, and I had the good fortune to sit next to Wilbur Cohen at a conference in 1988, where he talked to, and I got to ask him about, what was the plan? And of course, the plan was that you start with seniors and then open the program up gradually to the rest of the population. And as I've told students for 30 years in my classrooms, we haven't taken the second step yet. It's like we're in suspended animation. So 51 years ago, or 53 years ago now, we took the first step, and we're still waiting to take that next step of who's the next big portion of the population that we're going to let into the Medicare program. And I'm not personally convinced that the existing Medicare program is the correct program for a national health insurance system, but in some sense, politically, it's the easiest thing that we can do. And then if we need to make changes to the insurance benefits, to the way co-payments, whether or not we want to allow people to be in managed care plans versus fee-for-service plans, we can address that later. But opening up the program having it financed through either payroll taxes or general tax revenue, to me seems to be where we ultimately need to go.
And one thing about Medicare is, you know, right now when you think about it, although there are so many healthy people over the age of 65, you know, until you're 65, your employer generally covers your coverage, right? And then after 65, if you develop multiple medical conditions and things, the government's on the hook for your coverage. And in spite of that, they do a better job of controlling costs than the private sector. The other thing I will say is that that's one of the ideas that's being floated by the Center for American Progress, is to allow people to buy into sort of a Medicare as sort of the public option component. And where I think that could actually help seniors is if you have a younger pool that's buying into that, you could actually provide cash. You always hear Medicare is going broke. Well, you could actually provide some diversification of the risk pool and maybe further strengthen Medicare. Maybe that would also eventually allow Congress to say, oh, we're going to negotiate drug prices for Medicare. But, you know, again, these are some of the other alternatives that are out there. Whether or not that even that gets through in this environment in DC, that's a whole other question.
So you just touched on alternatives to strictly single-payer conditions, but I want to bring up one of the big concerns that people have about single-payer. That's about 150 million Americans currently receive employer-based health care. So under most versions of single-payer, they are not able to keep this insurance plan. So these public option plans that you're talking about as a road to single-payer, are these the first step that we would need to take?
So I'll start. So this is one of the major political obstacles, convincing people who are, look, if you survey individuals who have employment-based insurance, and I have to make a disclaimer here, I sit on the board of the University of California Health Benefits, it's the Executive Steering Committee for Health Benefits. So I'm one of 5 voting members, I'm a faculty representative, and we are responsible for selecting health benefits for the University of California.